It's really humbling to be among you, and quite difficult to follow that very eloquent and moving story from Peter. So I'm going to hide over here and behind the crutch of a PowerPoint instead. But the other human element I'm bringing here is I brought three members of my team who represent if you like, the hierarchy of progression within research. I've got a postdoc and neurosurgical trainee, Abtin Mustafi, there in the middle. My PhD student, another neurosurgical trainee, Alex Alamri, and a psychology graduate and research assistant, Brian Ishihara here. And all of these people, some of them their salaries and their scientific equipment is funded by this SR grant. And indeed, it's one of my first significant research grants. So thank you so much, and I do agree with Peter that do please keep giving and supporting such research. So I wanted to talk about surgical treatments for spinal cord injury pain. These were done a lot half a century ago, and then I think there became less awareness about them from physicians, and to some extent they're a little bit of a lost art, and I think one of my passions is revisiting that lost art for difficult to treat pain problems. You'll be familiar with the burden of pain in spinal cord injury. This is an American paper from a decade ago which highlights that many people with chronic pain in spinal cord injury also have depression and poor sleep, and that only a minority are able to still work, and just over half able to engage in what they feel are good activities for their quality of life. So clearly there is a great burden of pain in spinal cord injury in terms of how it affects people. And you'll all be familiar with the different types and strengths of painkillers, opioids, neuropathic analgesics, non-steroidal anti-inflammatories. But there's perhaps a fourth step on the World Health Organization analgesic ladder for interventions, including surgical interventions. This is from an article in the British Medical Journal about cancer pain, but equally it could apply to spinal cord injury pain. So there are a variety of targets from the peripheral nerve through the spinal cord up to the different bits of brain that are targeted by many weird and wonderfully named neurosurgical procedures. Indeed, there is probably no part of the brain and spine or peripheral nerve that hasn't been attacked in the neurosurgeon's quest to conquer pain. And here are the names of some. In red, I've put those which essentially involve cutting a part of the nervous system, and in green, I've put those that involve putting a device into the nervous system. And if I simplify those to ones that are not, one is still able to do in the NHS and are not historical or not funded because of a lack of evidence, then one's left with cingulotomy and thalamotomy, which are ways of focally damaging parts of the brain involved in pain processing, cordotomy and myelotomy, which are ways of damaging the spine in a focal way to alter the pain tracts, spinal cord stimulation, which is essentially putting a pacemaker into the spine, dorsal rhizotomy, which is cutting another part of the spine, placing pumps into the central nervous system, into the spinal cord area, injecting phenol, which is a way of damaging the spine, or stimulating the peripheral nerves. And I'm just going to touch on each of those briefly and then end with the research. So these spine lesions essentially focally cut different parts of the spinal cord involved in pain processing. And the spinal cord has the motor parts at the front and sensory parts towards the side, and these different tracts are targeted in the different neurosurgical procedures. Cordotomy cuts the anterolateral spinothalamic tracts, DRES cuts the dorsal root entry zone at the back, and myelotomy is a cut down the middle between the dorsal columns where the sensation is carried. And these procedures are done in different ways. Cordotomy is the passing of a needle under a CT scan to target that part in the awake patient, and then stimulating to see if that painful body part is covered before one performs the procedure. Myelotomy is good for abdominal or pelvic pain and involves cutting a lower part of the spine under a general anaesthetic. Dorsal root ganglion entry zone lesioning is done often for brachial plexus avulsion, which is an injury where the arm can be pulled, often in motorcycle injuries. And in some spinal cord injuries, the brachial plexus is avulsed, and that's an effective treatment for that. Many of these treatments are second line or last resort in the era of neuromodulation. Over the last couple of decades, pacemakers have been popularized, and the principle is that if you put an electrode on the spine, you send an electrical signal to the sensory areas, the dorsal columns, and that jams the aberrant pain signals. So now various parts of the brain and spine have been targeted for stimulation, and spinal cord stimulation is one of my first-line treatments for pain after spinal cord injury. This is an example of a spinal cord stimulator, a little paddle that's been put in the spine after an operation. And it's been connected to an external battery pack for a week or two for the patient to go home and keep a pain diary and see if their pain is improving. And should it be improving, then the expensive bit, the pacemaker, can be implanted in the tummy or the chest, for example, and deliver that current regularly. So there have been multiple randomized controlled trials of spinal cord stimulation. NICE supports it, NHS England funds it, and the main indications are probably actually those patients who've still got leg or back pain after failed back surgery. In spinal cord injury, it's more variable, the results, and the patient selection is key to that, and it's another area where we're doing research to try to find tools which enable us to select patients for best results. This is a recent systematic review and meta-analysis suggesting, broadly speaking, that 2/3 of patients have over 50% pain relief from this therapy. Then another treatment is intrathecal drug delivery pumps. These can either deliver morphine, a strong painkiller which enables you to bypass the gut and therefore not have the side effects of morphine upon the gut, and to give stronger doses, or baclofen can be given for spasms, which is another challenging problem in spinal cord injury. These are pumps about the size of an ice hockey puck that sit in the tummy and thread a little catheter round into the spine. They need to be changed every half decade, but they are a quite effective therapy. And then there are operations which target a part of the brain and perform a focal lesion in a part of the brain. There is a bit of the brain deep in its middle called the thalamus, which is a sort of gateway or filter to the senses and for our control of movement. And it has lots of different parts in, and some of those parts are particular to pain processing. So it's possible that one can make a little lesion there by heating a little probe in a surgical operation and relieve pain. And that's one of the procedures that I do and do quite a lot of research in. This video shows a lady who had severe arm pain and had such a procedure. And she's, if I can get it to work, she's just going to talk about the result of that. As you can see, she's got a little plaster and a 1-inch cut and 2 millimeter hole in there. So while it all sounds quite radical, it's quite a small operation. So that particular operation is good if you have pain in one particular body part, be it one arm or one leg. You can only perform it on one side of the brain to treat one side of the body. And obviously that limits its usefulness in pain after spinal cord injury, where quite often patients have pain below a certain level on both sides of the body. So there's another procedure called cingulotomy, which is essentially doing a focal lesion and burning a little bit of brain to do with the perception of pain and whether the pain is bothersome. And whether it's cingulotomy or thalamotomy, the procedure involves fixing a frame to the head so one can very accurately get to that correct bit of brain. And while it looks rather barbaric, from the point of view of pain caused during surgery, it's actually, people tell me it's better than the dentist, or the patients do at least. There's local anesthetic for the 1-inch cut. Once you're inside the brain, there are no pain sensors there, so that little bit is not comfortable. In the interest of time, I haven't included a video of this surgery, but there is one on YouTube if you Google me or you Google pain surgery of this surgery being done, narrated by Mr. Mustafi. So what does the anterior cingulate cortex do? Well, it's a part of the brain involved in the perception of emotions and pain, but also affect, mood, and potentially interoception, the sense of one's internal milieu. And it also has a role in controlling blood pressure and heart rate and autonomic function. And all of these things are related, one's mood and one's pain, to one's heart rate and blood pressure. And where is a cingulotomy lesion? Well, these are MRI scans after such a operation, and you can see a cylindrical 1 centimetre by 2 centimetre focal bit of brain damage performed there to relieve pain. And broadly speaking, 2/3 of patients have a significant improvement. I've reviewed the literature a decade ago. It's mainly a cancer pain literature, and it's mainly from the 1950s to the 1990s, because this is an operation that's a little bit of a lost art. As are many of these surgeries, if you look at academic publications on lesional surgeries damaging the brain or the spine to try to relieve pain, then they dropped off after the 80s, and one of the reasons for that is the invention of stimulators and a preference for that, and another reason is more sophisticated medicines like opiates and their derivatives. If you look at the number of publications by treatment, this reflects that the majority of people performing these treatments where there's a lot of publications are pain doctors, and neurosurgeons form a minority of the specialists who see people with neuropathic pain. So cordotomy, which is performed by pain doctors by and large, has quite a lot of publications, whereas cingulotomy doesn't have that many. They're small studies, they're mostly case series. It's difficult to do a randomized controlled trial where there's a control arm and you drill a hole in the head. So you have to be careful with how you design the case series. So what are we doing with this research? Well, we're studying, we are firstly recruiting patients with severe spinal cord injury or severe pain from spinal cord injury, and I see a handful of such patients every month at St George's, often referred from Stoke, Mandeville and Stanmore, some of them from the wider region. And in the first instance, I'm a single point of access to all of those therapies. So many of these patients are more suitable for a spinal cord stimulator or a pump, or indeed some alteration of their medication with the multidisciplinary team. And those that aren't are potentially candidates for the cingulotomy procedure, those who have severe pain below a certain level, which may have not responded to the other treatments. We are recruiting 12 patients to study intensively over 3 years, and we're studying them before the procedure and at 3-month and 12-month time points. And the particular things that we are studying, as well as measuring their pain before and after the procedure and getting MRI brain scans to see anatomically and mechanistically what we're doing, is we're measuring something called their heart rate variability, and we're measuring their interoception, their sense of their internal milieu. And we're using a laser-evoked potential machine, which is something bought by the grant, to cause acute pain and see the brain's response to that and the patient's response to that. So what is heart rate variability? Well, it's, technically speaking, the variation between the different heartbeats. So if your heart beats 60 times in a minute, then the distance between those two beats, it might be 1.02 seconds or it might be 0.98 seconds. And when you do some fancy maths on all of that, it gives you a measure of how strong your sympathetic tone is, or your vagal tone, or your parasympathetic tone is. In other words, whether you're in more of a flight or flight mode, or whether you're in more of a sort of sated postprandial mode, for example. And there are different theories about the relationship between heart rate variability and pain, that when we're in a more of a fight or flight mode, that our pain is suppressed, for example, or when we're in more of a sated mode, our pain is suppressed. So potentially, this is an objective, measurable entity that will help us select patients for these surgeries so that we can select those who have the best outcome. It may be that someone has a certain pattern of heart rate variability that means they might be a good responder to some of these treatments and that someone else doesn't. So we're measuring heart rate variability in these patients, and this has actually over the last couple of years become quite quite a popular thing to measure. Most of these sort of Fitbits and other types of watches come out with some measure of your wellness and your sleep that is an aggregate that uses this marker. So to acquire it in its raw form and look at it in patients with severe chronic pain and with spinal cord injury and the effect of surgical treatments is really the thrust of this research. And then the other measure is interoception. It is trying to objectively evaluate a patient's awareness of their sense of their internal milieu. So you could hypothesize that if you damage that somebody who has severe pain is either hypersensitized and is a bit too aware of their internal milieu, and that by damaging this little bit of brain, you reset that, or you could hypothesize that it's the other way around, and we don't know the answer to that. So simple tasks like asking a patient to count their heartbeat and see how accurately they can estimate their heartbeat are ways of measuring that, and there's a whole literature on how to do that. So to summarize, neurosurgical lesions for pain are not just historical, and hopefully you might agree not entirely barbaric and quite focused therapies performed by highly trained professionals. Intrathecal drug delivery pumps are useful for spasms in the case of baclofen or morphine, and they can reduce the side effects of such drugs in high doses. Spinal cord stimulation is an established low-risk therapy with multiple indications, not just spinal cord injury. Brain stimulation for pain is not something I've talked about because it's something that is not supported in the NHS. However, lesional brain surgeries remain so, and it's one of the reasons that we've structured a trial around them. And what we really lack in pain is objective physiological biomarkers, some kind of reading that can tell us the severity of a person's pain and its quality in some detail that helps us select such patients and get the best surgical outcomes for them. Thank you very much.